Mm. Hello to everyone. A very warm welcome from me. I'm Luciano Saso. I'm a professor at Sapienza University of Rome, a member of the M80 Alliance. A very warm welcome to this session on the impact of COVID-19 on migrant and refugee health, which is a topic very important for the M80 Alliance. We organize several sessions on this topic at meetings like this in Berlin, the main World Health Summit, also at regional meetings. And also a few years ago, before COVID, we started a series of expert meetings on this topic of migrant and refugee health, organized in Rome at Sapienza University. And we did 3 of them in 2017, 18, and 19. And unfortunately, we had to change the strategy because of COVID came. And we transformed this series of expert meetings in a series of webinars, very well attended. I'm really happy about the community that we created within the M80 Alliance, because many colleagues connected and participated in a very active way from different parts of the world in webinars that we organized since January this year on different topics, including, of course, COVID. In January, we started with that topic, but then we moved to other very important aspects, like looking at migration and health in areas in which migration is really massive, and then also on topics like looking at how to reach migrant and refugees in this difficult period, how to reach undocumented migrants, digital solutions for all these issues, reproductive and sexual health, also education, how to improve education in medical professions, and try to have the topic of migrant and refugee health well taught to our students and graduate students as well. And now actually we are planning very soon in November another event on the impact of climate change on migration and health. And this is, of course, is very important. We have, as you know, the COP26 in Glasgow upcoming very soon. So this also will be a topic. So we try to actually deal with different, again, aspects on different angles. And today we have very distinguished speakers to talk about the impact of COVID-19 on migration and health. I want to thank, first of all, my co-chair, Professor Amir Takian, who is Vice Dean of the School of Public Health at Tehran University of Medical Sciences. And together we will moderate this session with different speakers from different parts of the world. And we will introduce the speakers, one by one before their talk. And then we will open the discussion, here with colleagues in the room, but also we hope to have a very good participation from colleagues connected online. This is the new normal. We try to organize these events in a hybrid way. And again, thank you to all the participants also online. So without further ado, I leave the floor to my co-chair, Professor Tagian.
Thank you very much, Professor Saso. Good afternoon. Welcome to this session on migration and refugees' health during COVID-19. I'm so glad that the joint effort of Sapienza University and Tehran University of Medical Sciences has come to this M8 Alliance supported session, and the distinguished guests who have accepted our invitation. As you know, about 272 million refugees and asylum seekers around the world, they have been disproportionately affected by the COVID-19, and this has been because of the personal, social, and infrastructural and health factors. And for instance, within the countries, there have been some internal displaced people who have been stranded to go out to other countries to visit their families. There have been less access to some personal equipments, protection equipments, and vaccines, even though there are some reports by WHO, recent report by WHO showing that undocumented and documented refugees in many countries have had equal access to the services, but the magnitude of their access to vaccine, the discrimination against them, there are some reports from some certain countries that, for instance, there have been discrimination and lack of access to some kind of facilities. I come from the Middle East, and there are many countries, almost half of the world refugee population are in the Middle East, and we will hear from Dr. Akihiro about the Palestinian issues, and the organization that he's leading already access to healthcare services for refugees was somehow very restricted for some countries. And the COVID-19, unfortunately, has been adding to the burden of access to even normal care among those refugees. And that's why I think this panel is bringing a number of considerations for policymakers and how we can actually tackle this discrimination and how we can actually address the long-standing challenges of refugees in terms of affordability, access to the healthcare services, the language barriers that they have, and the exacerbated barriers due to COVID-19 and these very vulnerable people, specifically the vulnerable of the vulnerable who are pregnant women, for instance, and children, elderly people, disabled people, and people with underlying communicable and non-communicable diseases who are among refugees might have been affected more. We don't have any kind of solid data to show and to see to what extent they have been affected. This is a kind of ongoing research, but I guess this should be a kind of very urgent and ongoing discussion among the policymakers and the researchers and the community and the politicians, how we need to address this big proportion of refugees. With that, the session will be around 2 interventions. So each speaker, in order, we will ask him to speak about 6 minutes, and then after that, we will have after all the six speakers have finished their first addresses, then we have a round of questions from you. Feel free to text your questions through the chat or raise your hand, those of who are in the room, and then we will give you the floor to raise your questions. And after the first round of questions, again, we go back to the speakers and ask them the second round of interventions for 3 minutes before the 2 chairs will conclude the session. And I hope you will enjoy that. And with no further ado, it's my great honor and pleasure to introduce our first speaker, Professor Alexander Kramer. Professor Kramer is a very great friend and collaborator of mine. I have had the pleasure to working with him in different research collaborations. He's a senior professor and director of research program Refugee Health Fluge at the School of Public Health, the University of Bielefeld in Germany, and he will be talking about COVID-19 and migrants, refugees, only one crisis among others, common causes, patterns, and dynamics. Professor Kramer, the floor is yours.
Thank you very much, dear Amir, for this very nice introduction. Good afternoon, ladies and gentlemen. I try to put actually the problem into perspective. If I may have the second slide. Thank you. So world humanity and our field of public health have been struck and concerned with 4 major crises. The financial and economical crisis of 2007-2008, which is not listed here on this slide. Then, as you see, the so-called refugee crisis that has hit Germany recently, 2015 and 2016, but also other European and other countries, and is an international global phenomenon. Then also climate change, and we have the COVID-19 pandemic. And the interesting thing with respect to all these problems in public health and medicine that they show common features regarding the global dimension of all of them. And in spite of the global dimension, there are certainly regional differences between different countries and different regions. And then all of these crises assemble a certain kind of complexity, a very high complexity, and they are also related to each other in very complex interactions and interdigitations. So they are not independent from each other. And above all, health is a dominant feature of all of these crises, which is important insofar as mitigation and control of these crises may impair population health of the countries that are affected. But on the other hand, health can also be used as a motivator for health policy and politicians in general to control these epidemics. And we as public health people are advocates for pointing out the importance of health in this dimension. And then all these crises are concerned with a certain urgency, particularly infectious diseases such as COVID-19, but of course also climate change, where every day that is lost combating climate change is a lost day. Another very important aspect is governance. And what we observe regarding governance is that weaknesses of governance exist on the global dimension. For example, the weakness of the United Nations, but also the weakness of WHO and the European Union is very important. For example, with respect to the European Union, there's no regulation still for Europe about the distribution of refugees into the different European countries, which is very bad and have to be solved. Here you see the development of the monthly asylum applications in Germany over the last 2 years. And you see the dip in the first applications in red, and also the green ones. These are the second and the following applications in the spring of 2020. And this is related to the COVID-19 pandemic, where fewer people came to Germany. And after that, then the numbers grew up again and reached the level of before. And in Germany, we expect, due to the crisis in Afghanistan, more people from Afghanistan also coming in the future. What you also see here on the level of the European Union in this slide, you see that this dip in the spring of 2020 was even more pronounced in the European Union as a whole. There may be other reasons for this dip besides the pandemic of COVID-19, but COVID-19 certainly is one of the major reasons for that. And after the dip, we see an increase again, but the numbers have not reached the level from before. Now, again, as we know, COVID-19 is a deadly infectious disease hitting the populations very hard. And with projections and extrapolations from the beginning of the epidemic, you see that it's now ranking second after tuberculosis, before HIV and AIDS and malaria as a deadly infectious disease. Not only that, but through the absorption of the healthcare system of especially poorer countries in the south that are concerned with tropical diseases and also healthcare workers, the fight against these other major infectious diseases like tuberculosis, HIV, and malaria is weakened, and the incidences for these diseases are already increasing. Then I would like to mention something about the so-called syndemic, about COVID-19 epidemic and other simultaneously or in parallel occurring diseases, such as chronic diseases like cardiovascular disease, cancer, and other chronic diseases. What you see here is, given HIV infection, the difference between the North and the South with respect to severe outcome of infection. Unlike the picture of the world that we are used to with respect to climate change, infectious diseases, burden of disease in general, and other hazards and health threats, we see here a different picture where the North has an advancement compared a disadvancement compared to the South. The South is here advanced or advantaged, I have to say, sorry, advantaged, whereas in the North you see the syndemic due to the longer life expectancy of the pandemic on the one hand side, and also the association due to longer life expectancy with chronic diseases which demonstrates then severe outcomes, especially in the elderly population. Whereas in the south, due to lower life expectancy, we do not see so many severe infections so far, although we see certainly also severe outcomes of infection, and we have many problems in the south, and it certainly does not mean, this picture of this endemic situation, that we are not having to support the south from the rich countries. On the contrary, is certainly very necessary, and you will see this in my last slide, where you see these catastrophically low vaccination rates in the south, especially in sub-Saharan Africa and some other countries, where only a few % of the population have been vaccinated. This is due to the fact that they are not supported strongly enough by richer countries in the north, and they do not have facilities to produce vaccines themselves. There are many issues regarding this that have been also addressed during this conference, but this situation, if it's not going to be resolved, will soon backfire, or has already backfired politically, and will also backfire medically and epidemiologically, because it's certainly very necessary that a pandemic is controlled not only in certain countries, but all over the world. But Amir has already addressed the issue that refugees and migrants are a very, very vulnerable population, also with respect to acquisition of the infection and also severe outcomes, for example, also in richer countries. And the other presenters will also talk about this now in the rest of our conversation here. Thank you very much.
Thank you very much, Professor Kramer. Given your very long standing in this research about the issues of refugees, specifically in Germany, you raised a number of concerns that we need to consider, and somehow painted the picture, the current picture that we have, with good examples, and hopefully we will have time to come to the questions. I just want to encourage you to put all questions in the chat box, or those in the room, you can raise your hands and during the question time so we can address them. The second speaker I have a pleasure to invite is Dr. is here?
I can see that you actually, we did not see you before, Manuel, so it's a pleasure to see you online. So it's a pleasure to introduce Dr. Manuel Carballo, the Executive Director of the International Center for Migration, Health and Development in Geneva. He will give a talk on COVID-19 and migrants and refugees, what we learn and still have to do. And Manuel Carballo is a very known figure in the field. He doesn't need a long introduction, but in a few words, we can say that he's an epidemiologist and a graduate of Leeds University and Tulane School of Public Health and Tropical Medicine and CDC. He's the Executive Director of the International Center for Migration, Health and Development in Geneva. And he was previously a senior scientist at WHO, and he worked in several countries. We can mention, for the sake of time, just to some of the points of his incredible and very rich CV. He has been also leading a series of COVID-19 guidance notes on community quarantine, migrants, humanitarian crisis, and midwifery. So please, Manuel, the floor is yours.
Thank you very much for that introduction. And thank you, Amir and Professor Kramer, because I think you've set the scene very well for this situation. My first slide, and now I'm going to get lost in trying to show them there.
If you can share your screen.
Yeah. So my first slide, it's not working. Anyway, share. Can you see it?
Yes.
Yeah. So
presentation mode, please.
Manuel, if you can put it on the slideshow, that would be helpful.
Yeah.
Yes, down.
There. Is that good?
Perfect.
Fantastic.
Good. So what I thought it would be important to say, first of all, is that COVID-19 has come along at a very critical time in our history. I personally think that migration will end up being one of the most important demographic, social, and economic phenomena that the world will see, that our world will see. The first point, and I think Professor Kramer has brought up already, is the accelerating climate change and environmental degradation. This is one of the factors that is going to displace over the next few years, maybe 250 million people. And this is going to be critically important from a political, economic, as well as a health perspective. The other point is that the growing real and perceived poverty. What I mean by this is poverty has been around forever. But today, I think that many people who were poor and didn't realize that they were poor now understand that their poverty in relation to the wealth that they see in other parts of the world. Another fact is the growing state and fragility and conflict. We have never seen as many refugees and internally displaced people as we are doing today. And I think it's very important that Professor Amir brought this issue up of internal displacement, but also the question of internal migration, which we know relatively little about. The other point I think is worth noting is the widening world view of everyone in the world. We know more about other countries than ever before. People in small villages in the highlands of Nepal know about the UK, the European Union, the United States. And this is a constant, shall we say, attraction for them. And then the other point is that there's a growing real and perceived need for workers. And I say perceived as well as real, because there are many countries of Europe that deny that they need migrants, when in fact they have never needed migrants as well, as much as they do today. Migrants understand this. People who are trafficking migrants understand this. And this is going to be an ongoing problem or challenge that we will all face. And the real challenge, of course, is the growing resistance to migrants and refugees. We have, in the last 50 years, we have probably never seen as strong a resistance to migrants and refugees as we are seeing today. Now, I think COVID-19 pandemic has probably reminded us of a number of things. First of all, that migrants and refugees, we talk about these in very general terms. They are socially, culturally, biologically, extremely heterogeneous populations. We have to be very careful when we talk about these populations, because one size does not fit all. And until we begin to disaggregate these populations in terms of socioeconomic background, cultural background, social background, we will not make much headway. We've also, I think, seen as a result of COVID-19 that most countries do not report or underreport migrant and refugee health, particularly, I think, refugee health in recent times. Migrant health is, on the whole, underreported. The other thing that has come out very strongly is that migrants have a heightened social, and I'm saying migrants now, not migrants and refugees, because the data I've looked at is more particularly migrant related, often have heightened social and biological risk factors. For example, if we look at the prevalence of type 2 diabetes, the prevalence of obesity, the prevalence of other respiratory infections, all of which are risk factors not for acquiring COVID-19, but for having severe complications of COVID-19. These are all heightened risks among migrant populations. No matter which country in Europe or the United States or other parts of the world that you look at, they come out very, very high on terms of biological risk factors. Professor Amir started out saying that the pandemic has disproportionately affected migrants and possibly refugees. And I think this is something that we need to keep in mind throughout the discussion, namely that they have stood out as a population that is disproportionately represented, not only in terms of incidence and prevalence of COVID-19, but also in terms of access to services, and biological outcomes. The other thing that has come out very clearly is that poor communication in the language of host societies seems to have pervaded much of the access to care. These issues that I've just listed here, we have known for a long time because they relate to migrants in general and possibly refugees, and with respect to other diseases. And by the way, Professor Kramer, I'm so happy that you have mentioned the other diseases that are affecting refugees and migrants, and which we do need to keep in mind, because COVID-19 is just another problem that they're facing. On this list here, I think that the main thing that I want to point out is that many governments have relied on NGOs to reach out to migrants. They have themselves taken what I call a benign neglect approach to migrants and refugees. Now, irregular migrants appear to have had higher rates than regular migrants from the data that are currently available. Interestingly enough, and perhaps with serious implications, they have tended to present with COVID-19 later than host population. In other words, they've gone to see doctors, hospitals or whatever, later in the infection than host populations have tended to do. And they've had clearly worse outcomes, including mortality. Now, if we look at specific cases, for example, Sweden in the end of 2020 was reporting that 32% of the people testing positive for C19 came from Turkey, Ethiopia, and Somalia. That is to say that out of what is a relatively small migrant population in Sweden, nevertheless, that population constituted 32% of all C19 COVID-19 cases in Sweden. In Norway, it was 42% with the prevalence primarily coming from Somalia. In Ontario, Canada, 44% of those testing for C19 COVID-19 were migrants. Now, it's important that, as from what data we have, refugees seem to be more likely to test positive than migrants. And I think this raises the question of the conditions in which refugees are being housed, particularly in situations such as Libya. Now, one of the other things that has come out very clearly is that the approach that has been taken by governments, by IOM, by UNHCR, at a particular point in time, was to close down the movement of migrants and refugees. I don't think that at any point in time did we take into account what the impact of this would be on a non-COVID-19 pandemic perspective. In other words, the economic implications of this were far-reaching, but more particularly, access to health care and the impact this has had on mental and physical health of migrants has been, and I use the word very cautiously, has been disastrous. Suddenly, mobility of migrants was closed. The opportunity to go back home was closed when their employment ended. The opportunity to move around in search of health care was limited. So these are things that came about as a result of the closure, which from a pandemic prevention and management perspective were very logical, but which nevertheless impacted severely on the health and welfare, physical and mental, of migrants. The other thing that has come out is that the living and socio-physical conditions of migrants and refugees is, in principle, throughout the world, extremely deleterious to good health and welfare. Overcrowding, poor physical conditions of housing, which have been mentioned by many, many people in the literature for a long time. I think for the first time we've realized how important this is for infectious airborne diseases. And given that this is not the last of the pandemics that we will see, either of a viral or bacterial nature, it is extremely important that we keep in mind that the physical situation in which people are being housed is critical to their health. I'm going to stop there, and then we will come back, I'm sure, to some of these issues later. Thank you very much.
Thank you very much, Dr. Carballo, for this inspiring talk. And now we proceed with the next speaker.
The next speaker, we move to Australia, and we have a pleasure to have virtually with us Dr. Christopher Lemma. Christopher is the clinical lead at the Monash Refugee Health and Wellbeing Service at Monash Health, adjunct senior lecturer at the School of Clinical Sciences at Monash Health, Monash University, Australia, among many other hats that he has he has been quite involved in this issue in one of the countries who accepts refugees. Christopher, please, floor is yours.
Thank you very much. I appreciate the invitation to speak. I'll just share my screen. So my name is Chris Lemma. This is actually my former job. I just left this wonderful service, but it's still within my memory to talk about it. First of all, I would like to acknowledge the traditional owners of the land from which I'm speaking. That's the Wurundjeri people and Bunurong people of the Kulin Nations, who are the traditional owners of the land on which I speak from. And I'd like to acknowledge their elders past and present, and also to pay my respects to any Indigenous people who are watching. So the Monash Refugee Health Service is a publicly funded state health service, which is part of one of the public hospitals in southern Australia in the southeast. You can see there that Australia is a colonial country. It was settled by the British on the background of more than 60,000 years of Indigenous settlement. The formation of the modern nation of Australia was an explicitly white supremacist effort. There was a racist migration policy from the time it became a nation in 1901, with a preference for migration from the United Kingdom and other white nations. After the Second World War, there was increasing migration from southern European countries. And then finally, mainly in the 1970s, 80s, and thereafter, migration from other areas of the world, such as Africa and Asia. And now it's a very multicultural country. More than half of the settler population of Australia has either a parent born overseas or are born overseas themselves. One of the more notorious sort of relics of this previous settlement policy, though, is our very hard and harsh treatment of asylum seekers and people who are undocumented migrants. And you may have seen that this is actually now a model for the treatment of asylum seekers in some European countries as well, where people who are making their way by sea are not given the opportunity to settle in Australia, even if they're fleeing persecution and would be recognised as refugees. They're held in indefinite detention in other countries, and then not allowed to enjoy the rights that Australian citizens enjoy. That's a national policy. At a state level, because we are a federal country, and at a local government level, there are more sympathetic policies, such as in the area of Greater Dandenong, where our service is located. In southeast Melbourne, it's a very ethnically diverse area of the state. More than 500 different languages in our service's primary catchment. Very common languages other than English include Mandarin, Greek, Vietnamese, various Persian languages, Dari, Hazaragi, Farsi, and languages from India and other parts of Asia, as well as other parts of Europe. And these are the patients and the clients who attend our service. Our refugee health service is located in the community health program of our health network. And you can see there in the bottom left, that's our team in the pre-COVID days. You can see we're all close together and we're not wearing masks. I chose this picture because it it encapsulates quite a number of very relevant features of the service. So you can see there is a great diversity. There's people from all different parts of the world, all different continents, both directly coming there or for ancestry from different regions. We're all getting along very well. It's a very strong, cohesive team, and it's a very multidisciplinary team. We have specialist doctors, we have general practitioners, social workers, community health workers, nurses, psychiatrists, psychologists, dietitians, all working together to provide holistic care to the refugees and asylum seekers whom we see. A large number of the health problems that we see are mental health problems and other primary health issues such as dental care. There are a number of infectious diseases that we see, particularly latent tuberculosis and viral hepatitis. The COVID-19 outbreak in Victoria in 2020 was quite an event. So even though it was not large by world standards, it really hit the city very hard. And you can see on the left, those are the local government areas, and you can see that the distribution of cases was very uneven. And if you know Melbourne, you know that those are the regions of lower socioeconomic status, often populated by newer migrants or historically disadvantaged populations. And those were the ones, as the previous speakers have said, who had the most chance of exposure, the least chance of avoiding exposure, and often burdened with chronic disease, which gave a higher risk of a poor outcome. The public health response in Victoria was very heavy-handed, very harsh, but effective in curtailing the number of cases. It was a very long lockdown, which only ended last week, where there was curfews, there was restriction of movement in public spaces, restriction of movement of visiting people in different houses, and only essential workers were allowed to go to work outside their houses. This did reduce the number of cases, but at a very heavy economic cost, and psychosocial burden was really quite noticeable. Refugees and asylum seekers felt this particularly harshly. There were, as I said, they were overrepresented in the COVID-19 infections. There's also, on the background of pre-existing poorer access to healthcare, chronic illnesses did not get the same attention which they would normally get. And this, in turn, increases people's vulnerability to poor outcomes from COVID-19, but in its own right can be problematic. And even things like physical inactivity and obesity became more of a problem. There was a heavy psychological burden with fear and anxiety, sense of helplessness, frustration, and confusion at the rapidly changing public information and the even more rapidly changing and detrimental misinformation, which spread widely through people's social media and through mass media. Economically, a lot of people lost their jobs, and those who were continuing to work were often working in very precarious conditions for very low pay and vulnerable to loss of that job at any time, and not really able to take measures to protect themselves against infection. And we saw people moving from poverty to frank destitution and subsistence on charity, even people who had previously been managing reasonably well. And our local charity organisations were picking that up quite a lot. Despite a lot of massive government aid, some of that government aid did actually, as a matter of policy, exclude people who were amongst our clients. Socially, people were both isolated in themselves and also from their families, both in country, if they were living in different houses, or transnationally, they were isolated from family in other countries, often families in other countries who were affected by more massive COVID-19 pandemics. So people were being exposed to news of their families overseas getting sick or dying, or not being able to access healthcare. And there was a bit of survivor guilt because there was actually a better access to healthcare in Australia, where we have a very strong publicly funded health system. And we did have a state policy that even people who are not eligible for the universal health insurance, which Australian citizen permanent residents have, that even people without access to that Medicare system should still be offered treatment at publicly funded state-run facilities if it were for emergency care. Unfortunately, we also did see evidence of racism and stigma. as frustrated people tend to label, fixate on differences and label and blame anybody for their misfortunes. We had an integrated response to this issue. So we were already a multidisciplinary service embedded in a community health program, which has chronic disease management and a lot of other features. We partnered strongly with the local communities, and I should have said that amongst our team, some of the staff are actually very well respected and well connected in local community associations, and all of those networks were brought into play to provide material and psychological support, as well as providing the information which informed our response. We have very close ties with the acute health services, such as our local public hospital. So people who were unwell could be rapidly provided access to necessary healthcare. And this was linked in with local government services and local charities who could provide material and psychological support. Our health department was a major source of information, but also they were often behind the eight ball with being able to provide access to information in appropriate languages, given the huge ethnic diversity in our population, but the sort of Anglophone hegemony, you could say, of our official information services. And I would also say that the police featured very heavily in enforcing public health orders. And so part of our response was actually partnering with our communities and acting as a mediating influence between communities and police and other officials to avoid over-policing and some difficult interactions there. So we had these challenges, which of course are news to nobody now. It's a new disease with a rapidly evolving scientific and folk understanding of what it is and what it means. The complexity of this disease was imposed on the existing complexities, both social and political, in our local level and across the nations from which our clients and our staff do come. There was often a mistrust of authorities and of outsiders, sometimes well justified, but that made it very hard to get this rapidly changing information across in a way that enabled people to act to protect themselves and their households. And unfortunately, there was the production of appropriate materials in languages that people could understand often seemed to be an afterthought. We had a very centralized authoritarian public health response, but unfortunately that was disconnected from the local community knowledge and the connections that would actually enable it to be effective. And part of our role in this was to bridge that gap, given that we had connections both in community and also in the official system. And unfortunately, internal communications did hamper the efficiency of some of our responses, particularly at a government level, but even within our very massive health service, we had our challenges there. And amongst all of this, all of the people involved as staff and volunteers had to deal with the impact of the pandemic and the public health restrictions on their own personal lives, which was quite a challenge, and the workload was quite immense. So we learned a lot of things. Community responses were actually very fast and creative, but not really sustainable as people suffered burnout or became unwell, ran out of money. Government has a lot more resources, but it is slow. And the best response is where there's a creative and complementary relationship between these two responses to challenges. And the key is really letting community lead and listening and supporting them. It all does come down to relationships and trusting relationships and being able to communicate clearly, both within our own organizations and outside to the community, and being able to learn to build on the successes which we have been able to achieve, but more importantly also to learn from our failures and not hold on stubbornly to things that don't work. These are lessons for future healthcare. One of the things that struck me about COVID-19 is that although it's a new disease, none of the lessons that it teaches us are new. It's just that they're being applied a bit more strictly than they have been in the past, and a lot faster tempo, so that we are learning these lessons within the space of a news cycle rather than over the course of years or decades. Addressing structural inequities is key. And having a community-led intersectional co-design approach where the lessons and the perspectives of the most affected populations are built into the response from the outset seems to be important, which we already knew, but we're not willing to put into practice a lot of the time. Empowering communities and adequately resourcing them is so important. And this needs to be underpinned by information, reliable data that's consistently collected, integrated, and then used by the people who need it best. That all sounds very complicated. The three sort of maxims that I sort of take from that is respect everyone. So view everyone as a person who's important, who's got something to contribute. Care for everyone, whether it's your clients, patients, staff, or the community. And don't be racist, which is actually something that's much harder to do in practice, both as individuals and as institutions than you might think. So I'd just like to thank the people who lie behind this. So Professor Andrew Block actually founded this refugee health service many years ago. Jackie McBride is the manager, and Chiedza Malunga is a team leader, and they're actually absolute dynamos. And we really owe most of this to their efforts. And I just see there on the left-hand side, our volunteers who have all come from asylum seeker and refugee backgrounds and have made a massive contribution to the service, and then go on to employment and to contribute to the community in a really, really valuable way. So thank you very much for your attention.
So thank you very much, Chris, for this excellent talk. Now we move from one M8 Alliance member, Monash, to another one at the University of Coimbra. We have the pleasure to have online our colleague Ana Corte Real from the Faculty of Medicine of the University of Coimbra in Portugal. And she will talk about challenges and future directions in healthcare accessibility following COVID-19 context. And also Ana Corte Real, she has a very rich CV, so I will read just a few elements. She has a PhD in medical sociology, very important in my view to have this also, look from, issues like sociology from the medical point of view, and a master's degree in legal medicine and forensic sciences. She's a member of the coordination board of the health management and direction course of the University of Coimbra in Portugal. So please, Ana, you have the floor.
Thank you for your kind presentation. Good afternoon, everyone. I am delighted to join this panel in the World Health Summit meeting. I will focus on the challenges of access to healthcare in the aftermath of COVID-19, as they relate to migration flow, and I will take a fresh look at blockchain technology as emerging direction. In order to introduce the topic, I will present some slides aiming to simplify the complexity of blockchain technology. Undocumented identity and partial or even absence of medical information have been issues studied concerning the migrant population, particularly the homeless and stateless, which are associated with increased difficulty in individual access to healthcare or appropriate healthcare, and increased health inequality from a global perspective. These challenges have been intensified with the COVID-19 pandemic and further underlined in the recent World Health Organization 2021 reports. Additionally, the pandemic brought a fresh look and discussion about the need for skills acquisition on consolidated data, transparency data, and efficiency of global surveillance. To address these challenges, research can be directed toward improving access to healthcare from the migrant and refugee populations. This can be done through the application of new digital technologies in achieving the goal of the 2030 Agenda, universal health coverage, ensuring healthy lives, and promoting well-being. The use of suitable health platform, like the Portuguese S-Clínico, enables the inclusion of the individual in the healthcare process, interacting the primary care in the left upper corner with differentiated health care or urgent services in the right lower corner by different institutions of the Portuguese National Health Service. The successful implementation of this platform enables evidence-based health by using international codification, in administrative and care workflows. The current limitation of this platform is a sluggish response in the face of heavy use, and this is a frequent concern with centralized systems. However, when moving from a national to a global context, new challenges arise, namely in the amounts of data to be analyzed for decision-making in a big data health space, allowing the interoperability among different systems. So we will direct these challenges to blockchain technology as a decentralized system where information, such as health records, are collected in blocks and appended to existing ones. The information is time-stamped and cryptographically signed to avoid tampering. A consensus algorithm is used by the peers to ensure the legitimacy of the data to be added. We can apply it in a global space of health data sharing, allowing selective health information to be shared among countries, such as Portugal, Brazil, Germany, and Turkey, as it presented in the figure, bringing together all the various national databases into an accessible and decentralized space, where each node holds a copy of the data, so it's not locked down in a single health service or institution. The inherent characteristics of blockchain, for example, integrity, accessibility, and security, in line with timestamping, cryptography, tokenization, and smart contracts tools, enable for equity in healthcare, namely for migrants and refugees. Thank you.
Thank you very much, Anna, for the insightful and very, very time-considering presentation. Much appreciated because we are somewhat behind the schedule. Our next speaker is Dr. Akihiro Sita, whom I know for many years as a very activist in human rights and working with refugees. He is the Director of Health at the United Nations Relief and Works Agency for Palestinian Refugees in the Near East, UNRWA, based in Amman, the capital of Jordan. He has been dealing with the issue for many years now. He's going to talk about COVID-19 and Palestinian refugees, opportunities, risk, and lessons for UNRWA refugees' health. Akihiro, thank you very much for making the way to Berlin from Amman, and the floor is yours.
Yeah, thank you very much. Good afternoon. My name is Seita, and I work for UNRWA, and we provide the primary health care for 5.7 million Palestinian refugees in Jordan, Gaza, Lebanon, Syria, and the West Bank, including East Jerusalem. And today I will share that our experience with the 141 clinics which we have in these 5 places. So I use the data of Gaza as an example. In Gaza, there are 2 million population, of which 1.3 million are Palestinian refugees. And the upper half is the COVID waves. Gaza is now ending a 3rd wave, and you can see exactly what's happening. And I use the example of Gaza, but it's the same for other places. The lower half, we have 22 clinics providing primary health care. And these are a number of daily consultation or visits since the beginning of the COVID-19. Of course, when the COVID-19 came, lockdown happens, and in place that the number of visitors decline. And also on top of it, we have a 11 days war this May. And the next slide will show you how we can respond to such a crisis to maintain the critical primary health care. Yep. So what we did first is the continuity of the care. We have 5.7 million refugees, and of which include 300,000 people with diabetes or hypertension. We have 90,000 new pregnancies every year. The continuity of such primary health care is extremely important. So the first thing first is make our health center COVID resilient, starting with the triage, as well as providing PPE and IPC for the staff. And followed by that, from this year, the antigen rapid diagnosis test in Gaza. Secondly, the continuity of care. Okay, thank you. 300,000 patients of diabetes. So we started providing the medicine to their homes in the time of a lockdown. At the same time that we started telemedicine since the beginning of this year, again, particularly in Gaza. The third is universality. We put the family medicine as a base of our primary health care, and which is still we are continuing this. But from the COVID era, we try to address vulnerability, gender-based violence, and mental health, psychosocial support, and sexual reproductive health and rights. All of which are based on our digital health or electronic medical records. We have an EMR for connecting all the 140 clinics, and it is in the cloud with 3 million patient records. And we introduced smartphone application for MCH, NCD. Did it work? I show 3 examples. One is the telemedicine on the left side. This is a number of cases Gaza. We have almost 450,000 calls this year, which is around 1/4 to 1/3 of medical consultation in Gaza in our clinics. That is very good. And the antigen rapid diagnosis test, Ministry of Health of Gaza donated the kits to us. And so we started antigen rapid diagnosis test with 55,000 tests this year. As you can see, positivity rate is quite high, and we are analyzing the reason why. But I think it clearly tells antigen rapid diagnosis test works in the primary health care setting, together with the Ministry of Health. And mental health, no doubt that it is on the rise. And this is a number of consultations we did of cases in Gaza since the beginning of the year. It looks good, but actually we are trying to catch up, and it's very difficult to catch up on the increasing needs for the mental health. So these are how it works. Of course, there are many challenges, another 3. One is staff infection. In UNRWA, we have 3,000 staff in health and 30,000 as a whole, and including a large chunk of the teachers in education. Health staff had the highest infection rate of 32%. So 1 out of health staff, 3 health staff are infected. That affects our service delivery. And of course, we promoted the vaccinations, and now I'm very pleased and proud to say that 98% of our health staff are now vaccinated. But reaching to this, we have lots of infections. And secondly, that the COVID-19 asks us to surge staff and more staff to respond, like telemedicine and others. Like the beautiful lady and taking telemedicine are our temporary staff, not the permanent staff. And in case of Gaza, only the 60% of the staff are fixed term. And then we have used other resources to have a temporary staff, a job creation program. It's offering the service support to the refugees. And so this is not sustainable, and this remains a major challenge for us. And the host country's crisis, of course. So that back to our response to the COVID-19, I firstly said that how to reshape our primary health care in the COVID era. Second action we took is that working with the host countries and the partners. COVID-19, we have only the clinics. We cannot manage a PCR or the hospitalization. So it's important, the must, to work with the host countries. And then our first challenge is to access the COVID diagnosis test, it's a PCR and the admissions. In case of Jordan and Palestine, it works well. In Lebanon and Syria, because of the host country crisis, we have to pay. In Lebanon, for example, we pay $3.6 million for the admission, hospitalization of the COVID-19 cases among Palestinian refugees. And next one is access to the COVID vaccines. It worked well at the start. Jordan, Lebanon, Syria, and Palestine, they all included Palestinian refugees inclusively without any discrimination in the national vaccination plan. That's really good. I really appreciate this. And when they started receiving vaccine, it looks like it went well. However, like global vaccine inequality, that the host countries do not have enough vaccine, so as the Palestinian refugees, as shown in the rate in this here. So, what I learned in the reshaping the UNRWA and humanitarian health. Firstly, what I learned most is working and the supporting host countries is most important, very important. Of course, supporting UNRWA is very important, as you can see at the bottom of the slides. Please help us, we're in a financial crisis. But at the same time, host country support is very important to make sure that COVID-19 works. And then that because our Lebanon and the Syria host countries and in large extent Palestine itself are in crisis. And so that's important for the host country stability. Second is innovation global guide. Digital health, including our EMR, allow us to use that antigen rapid diagnostic test and the telemedicine. That is very good, so that the digitalization or digital transformation is important for us in UNRWA. At the same time, that to maintain the primary health care in the humanitarian setting, we need a global guidance. I think it would be great that in the World Health Summit and together with WHO develop such guidance, how to maintain primary health care in the humanitarian setting. And also that beyond health or universality of health, it was very clear. This is exactly what one of the Palestinian refugees in Lebanon told us. I would either die of COVID or poverty or run away. Yeah. So this is exactly the life of the Palestinian refugees and refugees in the world now. Last but least, still COVID-19 gave us opportunity for us to work together without boundaries, like this session. I think we are doing better than the COVID-19 virus. Thank you very much.
Thank you very much, Akihiro. Very interesting. Now, last but not least, we have as a speaker Swazik Elise Van Sonne. She's an economist, health specialist of the World Bank based in Washington, D.C. She will give a talk on profiling and socioeconomic determinants of vaccine acceptance among refugees in Kenya. Elise is a PhD research fellow in economics and governance from the United Nations University in the Netherlands. She's an economist and a young professional with a health, nutrition, and population unit of the World Bank Group in Washington, D.C., supporting projects across Africa and MENA countries, the Middle East and North Africa countries, to strengthen health systems in fragile and conflict-affected situations for a better response to the COVID-19 pandemic. So please, Elise, the floor is yours.
Thank you very much, Luciano, for the great introductions, and welcome, ladies and gentlemen, to this talk. I'm very happy to be part of this session, and the title of my talk is on profiling and socioeconomic determinant of vaccine acceptance among refugees in Kenya. So why do we care about refugees and access to vaccine in developing countries? So according to the latest figure, 87% of refugees are living in developing countries. It doesn't work. Yeah, so I was just saying that 87% of the world refugees are living in developing countries. And despite the fact that access to vaccine has been stubbornly low in low-income countries, there has been an increased advocacy of including refugees in national vaccine campaign very recently. And if you actually look at the data, 3% of people in low-income countries have received at least one dose of COVID-19 vaccine. And as I was saying, even though the COVID-19 vaccination campaign in Africa has been impeded by vaccine hesitancy due to social cultural belief, mistrust, and disinformation, there's still this drive that people have for refugees to be included in national COVID-19 vaccination campaign. But then we don't know much about what is really driving vaccine acceptance among refugees, especially in low-income countries. And if I take the case of Kenya, which is one of the most top refugee hosting countries in Africa, there has been a recent study that has evaluated for Kenyan nationals specifically what was the level and determinant of vaccine hesitancy among Kenyan nationals. And they found that the COVID-19 vaccine hesitancy in Kenya was high at 60%, and that age, education, concern regarding vaccine safety and effectiveness was one of the major factors that were driving the relatively low vaccine uptakes in Kenya. But then for refugees, we don't know much about what is really driving vaccine acceptance among refugees. And as I said, we believe it's a very relevant topic because Kenya is one of the top refugee hosting countries in Africa with 0.7% of the population being refugees. So how did we tackle this empirical question? We used the data that were collected by the UNHCR during the first quarter of 2021, so between January and June. And we use two core statistical techniques to be able to classify those among refugees that are accepting to take the vaccine and those that doesn't. And just as a matter of fact, so in general, first of all, we found that the vaccine acceptance among refugees is high at 86% as compared to 40% for Kenyan nationals. So who are the refugees that we are talking about in Kenya? So they are in majority Somalian and also those from South Sudan, the DRC, Ethiopia, and Sudan as well. And they are mostly young. So the data restricted the sample to people that are between 18 and at least 18 years old. But what we found out from the data that we got is that the majority of those refugees are between 18 and 35 years old. And in terms of their level of education, without no surprise, we found that most of them doesn't have a much advanced level of education. So they don't hold a university degree, but they do have primary education, or most of them, and the majority have no level of education. And in terms of so there were a couple of questions about whether they are trusting the government, where they live. So the majority, so we have 3 main refugee camps in Kenya. You have Dadaab, Kakuma, and Kalobeli, and this is what we found that was confirmed from the data. And in terms of the trust that they have from the government, so there was a question that the UNHCR asked to those refugees in order for them to know whether they are trusting government policy toward immigration. And some of them responded. So it's based on those characteristics that we were able to classify and define clusters of refugees that are pro-vaccine and those that are not willing to take the vaccine. So the first result from what we call a multiple correspondence analysis, which is a statistical techniques allowing us to do this classification, is that the level of education matter, the country of birth of refugees matter, whether they are living in an urban or rural area matters, but also in terms of the social capital that they have. So whether they are interacting with many people or whether they have interacted with many people over the past 7 days of the survey was also a driving factor that explained whether they are willing to take the vaccine, yes or no. And so for this variable, so basically what you find out, so from the left-hand side, these are the people that said they would like to take the vaccine. Those are those that are having an advanced level of education. So there were very few in the sample, but at least we found out that these are the people that are really, where the first axis were very correlated with the willingness of taking the COVID-19 vaccine. There are also mostly refugees from the DRC, living in the Kalobeli camp, and who have interacted with not so many people over the past 7 days of the survey, and also who are pretty much young. So those are the people that are between 18 and 25. And then on the left-hand side, those are the people that are not so willing to take the vaccine, and those are people that believe the government of Kenya policy towards migrants is not very trustable. So they were basically distrusting the government in terms of whether the government is in the right position to understand their concern. And also, we found out also that these are mostly Somalian refugees. So those are from Somalia, which are also the majority that are living in those refugee camps. And so this is just a figure that we draw from this multiple correspondence analysis to just show the divide and the profile of those refugees who are pro or non-pro COVID-19 vaccine. And we confirm this analysis using a logistic regression method. So basically, we do find that still, so even when doing an econometric regression, that education matter, the trust toward the government matter, and where the refugee is living in Kenya, so in which camp they are living, and what is their level of social capital, whether they are interacting more with people or no, but also household healthship. So whether they are head of household or no, it actually matters. And what we are trying to do, since this is a very preliminary result that we had, is to understand why those factors matters and try to do more robustness checks to be really sure that what we found here as drivers of COVID-19 uptake among refugees is indeed relevant and can have some external validity so that humanitarian organizations can use that for targeting refugees that are not so willing to be pro COVID-19 vaccine. So here I was just going through the different variable, highlighting them, but then I guess I summarize it, and I'm willing to come back to it during the opening question session. So in terms of conclusion and policy recommendation, just as we said. So those are household head, marital status, whether you are the type of camp you're living, the level of trust of the government on immigration policy, your social network, your level of anxiety toward COVID-19 pandemic, or whether you've had any symptoms, are all important socio-economic determinants of vaccine acceptance among refugees in Kenya. And what we are actually recommending in terms of policy is that humanitarian organizations that are willing to target refugees for COVID-19 vaccination campaign should actually rely on those drivers to identify those that are really willing to take the vaccine, or find strategies to make those that are not so willing to take it to adhere to the vaccine. So thank you very much, and I look forward to your question and suggestion to improve this research. Thank you.
Thank you very much, Elise, and all wonderful 6 speakers who shared with us the experiences. And we had a kind of very interesting and practical balance of policy considerations and ways of thinking about the governance of dealing with the refugees crisis, specifically during COVID-19, and some case studies, some real case studies from different countries for the refugees people. If there are some questions, please put it in the chat. So Luciano is so kind to take those questions coming from the chat. But if you guys from in the room, you have some specific questions, please raise your hand. Yes, please. And then please introduce yourself and then raise the question if you're a specifying question to any of the panelists, or is a general question, please.
Hi, my name is Laura Pleshnar. I'm the Regional Director for Europe in the International Federation of Medical Students Association. And coming from Croatia, it's a country that is on the Balkan route, and we do not have any health system for refugees implemented. And unfortunately, that's the situation for most Western Balkan countries. And even if there is some initiative, there is always big backlash. So what would you recommend for young health professionals that live in the parts of Europe where this topic is still a taboo? Thank you.
Thank you very much. So who wants to go first? And colleagues on Zoom, if you want to contribute to this question, we start from you and then we go to the speakers in the room. Any of you? Chris, Anna, Manuel?
Okay,
looks like Manuel wants to start, and then Chris.
I think the question that has just been raised is a very sad predicament, and I think the speaker is being very honest in saying, talking about Croatia and the Balkan route. She could, of course, been much more generalized. I think very few countries have developed the type of migrant and refugee friendly response, not only to COVID-19, but to other public health issues that are required. Now, the predicament for young health scientists, health workers right now, I think probably is to join NGOs and to work through the NGO system, recognizing that in many countries, Western European, Eastern European, and others, governments are increasingly giving over responsibility for migrant and refugee health to the NGO, non-governmental sector. This may, unfortunately, be the future of the healthcare system for these populations. Thank you.
Thank you, Manuel. Chris?
Thank you. Thank you, Laura, for the question. I think that's a valid response, but even more, I would say that young health professionals, particularly those from migrant and refugee backgrounds, need to actually act up and call their seniors, that's us, to account, and to use the privilege of their citizenship to mobilize political capital to change policy. I'm particularly interested in the Somali diaspora at the moment. I'd be really interested, Elise, to know what the connections between the people in the refugee camps in Kenya have with the both refugee populations in other countries, but also the healthcare workforce in other countries, in which migrants and refugees are overrepresented, and particularly the Somali diaspora.
Thank you very much, Chris. Anyone? Yeah.
Yeah, thank you very much. I think you already started raising question here. It's a great step. I think I really admire you. And the International Federation of Medical Students Association, we work together with the Lancet for the Palestine refugee. I think that's very important. For me, my honest advice, like what the previous speaker said, is that never forget anger, the situation of the world, and you should beat us, like what you said. The seniors are not doing anything, so you just raise the voice. But also practically, I think, I understand this is the only session for the humanitarian health in this World Health Summit. I think you can propose that together with the Professor Sasso that we can have a joint session next year, IFMS, and then the others to raise a refugee voice. I think that's very important. Thank you very much.
Thank you very much. Any other comments? Okay. Any further questions?
There is a comment, actually it's not a full question, but interesting from Fateme Nurolahi in the chat, and she mentioned among refugees, we found the widespread dominance of misinformation. Unfortunately, she did not mention exactly her affiliation, so we don't know exactly where she's based. But Christopher Lemo kindly, he replied that actually, unfortunately, this often looks more attractive than official misinformation. So we can continue maybe with some questions from the audience. In the meantime, we can also encourage us, there is one there, we encourage other colleagues to put questions in the chat, please.
Hello, my name is Stephanie Taché. I had a question to all the panelists, and many of you, particularly those presenting cases from the field, have mentioned the importance of trust. And I was wondering, because trust is such an essential part of addressing vaccine hesitancy, how do you translate that at a policy level? Thank you.
Also the colleagues on Zoom, if anyone would like to. Yeah. Yes, please, Chris. You raise your hand.
Thank you. Yes, Stephanie, that's a really key question as well. I think as a clinician, we get taught to assume trust as a basis for our practice, when what we really should be taught is how to achieve trust as the first step. And that also comes into governments and official agencies as well. Where there's a history of injustice, the first step is actually to acknowledge that and to work to achieve trust before proceeding to any sort of joint activity.
Please.
Thank you.
Yes. It's okay. I think what I learned in our setting is that the trust came when they see the vaccines abundantly available, particularly the one they like, which is Pfizer. And then so if there's Pfizer, Sinopharm, Sputnik, lots of them come into the market, and they change the behavior. We did a lot of education for the vaccine hesitancy. To be honest, that nothing worked until they saw the vaccines, and they can go to get the vaccine. Then their neighbors, family got the vaccine. They change the behavior. So I think the trust is very important, but in the political context, it is pretty tough. But once we have a vaccine, which people like to get it, I think there is a trust, or at least they will come and get the vaccine. That's what I learned.
Yeah, just to add to what Akiuho said, I think in the case of Kenya, the trust can also be built when policymakers themselves are taking the vaccine. So that's one of the first things. So what we found, even in the data set that we analyze, is when they ask them the question whether they are willing to take the vaccine if they see policymakers taking it first, then we tend to see like more high positive responses toward that question. So that's one way, but also through community health workers that are working on the field. There are a lot of behavioral campaigns that can be run on the ground to improve trust and enhance vaccine uptakes among either national or refugees. Thank you.
I think this is a very important question, but I think it's a very complex phenomenon, how to provide trust. Trust is something that can be provided by providing the right information about certain vaccines, but we know we have so many different vaccines. It's getting very complicated, and talking about their efficiency in relation to each other confuses people a lot. And I think it's not only a rationale phenomena, and not only, I mean, it's certainly important if the politicians get vaccinated themselves. I think that maybe provide some trust for certain people, but it's an irrational phenomenon to a certain degree. Also in Germany, because many people do not want to get vaccinated. And I think this is something that refers to the communication in the social media also, where you have wrong information in certain bubbles and everything. So it needs more research to understand how trust can be built. I think it's a very important issue.
Okay. Any further questions from the floor?
Yes.
No.
One general point that was raised in the beginning, and then also I want to reconnect to what Elise said yesterday in the open ceremony. No one is safe until everyone is safe. So in a way, COVID-19 brought this concept of solidarity, in terms of health in many societies. And we have to say that before COVID, this point was very much neglected, I would say, at least in European societies, in Western societies. And now I think we feel that we have to do this for the world in terms of COVID-19, but I think we need to expand more this concept, let's say, to migrant refugee health. Professor Kremer in the beginning remembered this crisis in which in Europe we had 1 million, refugees hosted very generously by Germany, and about 180,000 by Sweden and other countries. But overall, there were less than 2 million people, and that was considered a very huge crisis, despite the high number of population in Europe. So in the end, Europe was not able to address this issue properly because, in the end, the solidarity at that time was still low. So a general question for the panel, I mean, there is hope or not for our societies to be more generous and try to treat also the topic of migration and health in the same way? That is a global challenge that we all together we have to do more and not just wait for this tragedies to hit us before taking into consideration these problems.
Well, if I could just come in on the issue of trust and then come back to the Lucian's question. I think one of the things we need to keep in mind with refugees and migrants is that they have all moved because they have learned to distrust governance, governments, and people who have been making decisions for them. Gaining trust in this population is always going to be a major challenge. I think one of the things that we have not done sufficiently is give over responsibility for health, education, communication, and delivery of health services to people from within the refugee and population and migrant populations. All of these populations have highly trained people within them, doctors, nurses, lawyers, teachers, whatever. And we have disengaged and we disenfranchised these people from providing healthcare. We need to give over much more of that responsibility to people from within these populations. Coming back to Lucian's question about hope, I think we have to be optimistic. But the reality is that we're facing a global health crisis, and we have been extremely adept at disengaging from pandemic preparedness, pandemic prediction, allocation of resources to the health sector. So I am not particularly optimistic for the short term. Unfortunately, I'm not particularly optimistic with regard to the health and welfare of migrants and refugees, because I think as resources become more scarce, there will be less willingness to share what little we have in the health sector with migrants and refugees. We really need to go much more aggressively to encourage a view of migrants and refugees as essential to economic development. This is what I think is missing. We are not acknowledging how important they are for economic development. Thank you.
Chris.
Thank you. I am probably more optimistic, but I think COVID is a disease of disparity and a disease of inequity, and it's a disease of injustice, just like diabetes is, and just like smoking-related lung disease is. And I think the sooner that people become conscious of this and start to actively look at that justice aspect of it and the political aspect of it, that's when we will see some real change. We say that the health system is short of resources, but that's because there are decisions made to allocate those resources elsewhere. And it's a political question. We've got, money to buy nuclear submarines, but we don't have money to spend on healthcare. It's ridiculous. So I think it's really a case of becoming conscious of priorities and getting people to apply pressure, because that's the only way that the resources will come.
Thank you. Anna, if you have any comments, please.
Yes, some challenges can be highlighted and cross-referenced to all previous presentation in the scope of healthcare and the health system redesign. First, the need for consolidated data. Second, the need for transparency data. And third, the need for reliable real-time communication of the data. All these challenges have an impact on evidence-based policies. So we can discuss them strategically through a unique global space. And I believe, I'm optimist, that we can go through a digital solution like blockchain. And eventually, I challenges the different institutions and countries to cooperate in a global health space. Thank you.
Thank you very much. Alice, you want to go next?
No, maybe.
Oh, okay.
Thank you.
Yeah, I'm quite positive because that in all the meetings I attend, non-health, health is always the center. COVID-19. I think that's the world is changing. I receive lots of appreciation simply because I work in health. But so I think health is the center. I think that's changing, and also vaccine inequality is totally, absolutely wrong, and which everybody says so. And that's also very good that, I felt that left alone when I was trying to find a vaccine for Palestinian refugees. But here in the World Health Summit, each single one of us are saying this is wrong. I think it's a great thing. And the partnerships, allow me to share my very small experience. The United Nations have a country team, UN country team, which is different agency working, for example, Jordan, Palestine, Syria, and Lebanon. I have never seen that we are working such together, the UN different agencies, because the COVID brought us together. And we work very closely with the host country. So I think there is a good opportunity for the health. The challenge to us how to raise the profile of refugees and migrants. That is the biggest challenge, so that the world will never forget the refugees and migrants for the vulnerable people. I think that is we really need to continue to work hard.
Thank you much, Christoph. Alexander, sir.
I think there are different divergent movements here. So I have maybe centripetal movements where, due to the problem, every country, as we have seen in Europe at the beginning, particularly of the epidemic, only thinks about their own country, their nation, protection of their own national population, and so forth. On the other hand, there are also activities that are very positive regarding understanding that we have certain global problems we have to address, that we are sitting in the same boat, and it's certainly not clear how things will evolve in the future. But this pandemic gives you the opportunity to reflect, first of all, the relation between different problems to each other, that they are not distinct and can be separated, but that they relate to each other. And as I said, that we are sitting in the same boat, and that we have to take more responsibility, especially in the countries of the North and the rich countries.
Thank you. And Elise,
Yeah.
last but not least.
Definitely. So I will echo Akihiro by saying that I do have hope, mostly because more and more we see strong collaboration and partnership between development bank, humanitarian organizations to come together to close the vaccine inequity between high and low income countries, and this should continue that way. And as I said, I'm always advocating for not forgetting forcibly displaced population as much as possible. National government should include them in the rollout campaign. Thank you.
Thank you. We are reaching towards the end of this, and before I leave it to Professor Luciano, my distinguished co-chair, to finish, I just want to say that there are many examples of successful implementations of some good things for refugees. We heard some of them, but almost 3% of the world population are refugees, asylum seekers, migrants, and internal displaced people. And I think one of the main points, as mentioned by Manuel, was putting refugees as one of the pillars of sustainability, economic development. So this group of people in many countries have been very fundamental in terms of bringing economic progress. So we need to look at that. So we need to change the governance of the health system in a way that we can accommodate them. The second issue is how we can actually make this proportionate services for refugees towards more proportionate, specifically for the vulnerable groups. And the picture is not very promising, but we need to do something more in order to encourage the governments and NGOs and the funders to put more resources on that. And finally, if we want to have national security for specifically for the regions who are accepting a huge number of refugees, refugees' health is a part and one of the parts of the DNA for national security. So this language and this kind of discussions should be more often in the conferences, intersectorally, not just in the health sector, among different sectors in all societies. Professor Luciano, please.
Yes. So just to thank everyone, thank you very much to Professor Takian for co-chairing this session with me. Many thanks to the distinguished speakers in the room and online. Many thanks to the participants again in the room and online. And I want to also to thank very much the team, the World Health Summit team, for helping us in putting together this session. And we're looking forward to having you again in the next webinar. As I mentioned, will be on the 30th of November, and the topic will be the impact of climate change on migration and health. So thank you very much again, and see you soon.